endocrinology. In the endocrinology chapter, we are going to discuss actually a lot of things. So let's start with that actually. We finished GIT, by the way. So yeah, as you can see, for now, we finished all of the molecular biology, like 1 or 2 pages from the next chapter, which is the cellular biology. We finished the whole immunology, microbiology, and we finished pathology. So we have pharmacology and public health left. So the next system after endocrinology is going to be actually pharmacology. But during endocrinology, I will be doing cellular biochemistry, and during the pharmacology, I'm going to be doing the lab techniques in biochemistry. After we finish these systems, okay, just a sec. Can you see my screen now? Okay, so after we finish that, we are going to move on with the systems, and we will be done basically with all of the basic science and with 4 systems. And after that, it becomes just a piece of cake. Like this, what is left is easy. Some of them are a little bit lengthy, but they are not difficult. So let's take a look, maybe CNS a little bit. So now we are going to speak about hormones. So starting with the hypothalamic pituitary hormones. So first thing, for how long it will take to finish endo? Not much. So today in endocrinology, we'll finish 1, 2, 3, 4, 5, hopefully 6. And then, like on Monday, tomorrow is off, of course. This will be 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1 week. 1 week to finish endocrinology. So let's take a look. If we are speaking about the hypothalamic pituitary axis, what is that? Well, some hormones will be produced in the hypothalamus, and then they are going to be moving into the posterior pituitary. Yep, 1 week for endocrinology. It's not that long. So as you can see, some hormones will be produced in the hypothalamus, and then they are going to be moved into the posterior pituitary, also known as the neurohypophysis. Which 2 hormones are these? Which 2 hormones are produced in the hypothalamus, but they are released from the posterior pituitary? Excellent. It's antidiuretic hormone and also oxytocin. So take this. So as you can see here on the right, we have the paraventricular nuclei. They are producing the hormone like ADH, for example, and using something called neurophysin. Okay, using this thing, neurophysin, it's going to be going down to the posterior pituitary, and then it's going to be released from there to the circulation. Remember, the movement through the stalk is happening using an axon known as neurophysin. But if we are speaking about the other hormones, they use something called a portal system. We have 2 portal systems in our body. The first one is located in the GIT, and we spoke about that one. And the other one is located at the hypothalamic pituitary axis. They have something minor portal system, which is located here, which transmit the blood, which transmit the hormonated blood from point A to point B, which is the anterior pituitary. Okay. So let's take a look. Antidiuretic hormone increases the water permeability in the distal convoluted tubule and the collecting duct cells in the kidney to increase water reabsorption by mediating something called the aquaporine. So if you remember when we discussed the kidney, I was explaining this page for you. And I told you that the antidiuretic hormone, which was produced by the hypothalamus, released by the posterior pituitary, is going to work on the collecting duct, which increase the aquaporine production, which sucks the water from the tubules back to the body. Okay, so guys, what will happen to the sodium concentration if you have a lot of ADH? No. What is in the circulation? The sodium in the circulation. So obviously it's going to be up, and in the urine it's going to be down. Yes? So basically these patients who have major amount of ADH, they are going to suck a lot of water inside of their body, and that is going to dilute the blood and dilute the sodium in the blood. So it's a stimulate, the right clinical notes, stimulus for secretion is increase plasma osmolality. For example, some cases of hypernatremia will lead to increased ADH. Why? Because you want to make up for it. And, you want to dilute the plasma. Also, in cases of diabetic ketoacidosis and any cases of severe hyperosmolar hyperglycemia, which will a condition we'll speak about it later. Except some cases like SI-ADH, in which the ADH is elevated despite decrease in the plasma osmolality. So severe inappropriate antidiuretic hormone. It's inappropriate, which means it's released in a time that it should not be released, such, for example, after a trauma, or trauma to the head, or tumors of the lung, and others. Corticotropin releasing hormone. This hormone is produced by the hypothalamus, and it can lead to increase in the ACTH production in the pituitary gland, the adenohypophysis. Does anybody remember what is the embryological origin of the adenohypophysis? It was the Ratkes pouch. The Ratkes pouch. The adenohypophysis comes from the Ratkes pouch. But if we speak about the neurohypophysis, it comes from the diencephalon. Diencephalon. Okay, so they are basically two portions. So, two portions, posterior and anterior pituitary. The posterior one, also known as the neurohypophysis, comes from the diencephalon. The anterior one comes from the Ratkes pouch, which comes from oral ectoderm. Okay. So they write, corticotropin releasing hormone lead to an increase in the ACTH, MSH, and beta endorphin. Suspicious. These three, we saw them together before. You saw them together before when I was telling you about something called proopiomelanocortin, which is a major particle that can give rise for both beta endorphin, ACTH, and also MSH. So because it gives origin to all of these particles, these patients are going to, when they have high CRH, all of them are going also to get hyperpigmentation. So note, it decreases in chronic exogenous steroid use. Why? Because if you have a lot of steroid from the outside, there is no need to make more. So the ACTH will be down, the CRH will be down. And who takes steroids exogenously? Well, people with which type of disease? Autoimmune disease, absolutely. Yep. Okay, so the next one is dopamine. So dopamine has multiple function actually. It is produced mainly in the brain. Where exactly? Does anybody know where is dopamine released? Substantia nigra, which is located in which portion of the brain? the midbrain. It's a portion of the basal ganglia. You are correct, actually. So as you can see here, this is the midbrain, and there is this black substance. This is the substantia nigra. To be totally fair with you, they do show a gross image. Yes. And they give you an arrow here. See this black substance? This is the substantia nigra. So notice, which one of these two guys has Parkinson's disease? The right one or the left one? The left one, because he does not have substantia nigra. So the person without substantia nigra will have Parkinson's disease. Why? Because he does not have dopamine. That's what leads to the shaking. Okay, so the next thing we have, dopamine. So a lot of dopamine is going to work in a system that we will study in neurology called tubulo-infundibular system. And that the tubulo-infundibular system, when dopamine is high, prolactin becomes low. So when we give antipsychotics, what happens to the level of dopamine? Well, antipsychotics are basically antidopaminergic drug. So that decreases the dopamine. So if you decrease the dopamine, what is going to happen to the level of the prolactin? Up, absolutely. So people with antipsychotics, on antipsychotics, are going to get hyperprolactinemia. Also, dopamine can lead to increased TSH function, which will be important when we discuss hypo and hyperthyroidism. Also called the prolactin inhibiting factor, the dopamine. Dopamine antagonists like antipsychotic can cause galactorrhea due to hyperprolactinemia, which can lead to... What is galactorrhea, by the way, guys? Anybody know what is galactorrhea? It's when we have discharge from the breast, okay? Yes, milk from the breast or milk like... So, wait a second. Are you telling me like a 70-year-old can have milk out of her breast if she has a prolactinemia? 70-year-old. Absolutely. Do men have galactorrhea? No, that's the trick. Why men don't have galactorrhea? I will explain it in reproductive. We men have the acinos, but we don't have the duct. Okay? We do. It's funny, we do have the gland, but we do not have the ducts for it. So it's impossible for us to get the galactorrhea, but regardless, we can get the gynecomastia. Yeah? So, yes. Growth hormone releasing hormone. So that increased, well, logically, the growth hormone. Remember, a growth hormone mostly does not act directly. It acts by the increase of the release of what? IGF-1, which is insulin-like growth factor 1, which is produced by which organ? The answer is, where is IGF-1 produced? Guys, when you don't know the answer, what do you say? No, we don't say the pancreas when we don't know the answer. When we don't know the answer, we say the liver. So insulin-like, not insulin. Insulin-like growth factor. So that will be from the liver. Okay, so it's an analog. It has an analog, which is known as tisamorelin, which is used to treat HIV-associated lipodystrophy. And these patients, when they use this tisamorelin, they get more muscle, they get more fat, they become more stronger because HIV sucks. And they can get really severe type. Basically, we give them anabolic steroid to become more stronger. Also, a lot of people do consume anabolic steroid to become more stronger. Guys, one quick question. What happens to the size of the testicles in case of anabolic steroid usage? Smaller. Yep, they shrink. Okay, GnRH, gonadotropin releasing hormone. So the gonadotropin releasing hormone, as always, is secreted from the hypothalamus, and it can work by increasing the FSH and the LH, follicular stimulating hormone, and luteinizing hormone from the pituitary. Which pituitary? The anterior one. So it can be suppressed by hyperprolactinemia. This is important when you have a lot of prolactin that can suppress it. Let me tell you an indirect type of association. If you use an antipsychotic, what will happen to the dopamine? Yeah, that's true. But when we use an low dopamine, antipsychotic, low dopamine, what happens to the prolactin? Prolactin, high. When the prolactin is high, what is going to happen to the GnRH, which is gonadotropin releasing hormone? Low. It's going to become low. When it becomes low, what happens to the FSH and the LH? Also low, because it normally stimulates them to become more. So when he's low, they become low. When they are low, what is going to happen to the testosterone, estrogen, and the progesterone? The answer, that all of these are going to be low. Okay, I hope you got it. So when you use an antipsychotic, your GnRH is also going to go down, but indirectly. Why? Because antipsychotics increase the prolactin, which decreases the GnRH, which decreases the FSH and the LH, which decreases the testosterone, estrogen, and the progesterone. If I was you, I would totally draw this thing. I mean, dopamine relationship to prolactin, to GnRH, to FSH, LH, and then to the testosterone, estrogen, and the progesterone. Okay. So, the next one here, they are writing that GnRH can be suppressed by hyperprolactinemia. Tonic GnRH analog, like leuprolide, suppresses the hypothalamic pituitary gonadal axis. You are like, wait a second. So an analog means look like or the opposite. Tell me. When I say something is an analog of that drug, it means that it looks like it or it does not look like it. It looks like it, yeah? So leuprolide, which is an analog for GnRH, it can suppress the GnRH. How come? Well, let me tell you. It's all about how do you give it. Here they mention a really important word, tonic. So, let me make a little table here, just a graph. And I want you to be focused with this one because it's actually really important. So, let's give leuprolide, which is GnRH, yeah? Okay, so when you give it, look what happens. I'm giving it. If you give it in a pulsatile fashion, like this, I mean, give, don't give. Give, don't give. So that's we call pulsatile fashion. The level of LH and FSH is going to go up, okay? But if you do something like this, if you do give it, but you give it in a really high amount as a tonic fashion, okay? Tonic fashion, which is a continuous fashion. What is going to happen to the patient? Well, the answer actually, it's going to be the opposite. If it was here, the FSH and the LH, they are going to go down, okay? I hope it makes sense. So this is if you give the drug in a tonic fashion versus if you give it in a continuous fashion. The first one is which type? It is the continuous or the tonic fashion. And the second one is the continuous fashion. Okay? Sorry. So this one is it's the pulsatile type of flow. And this is the tonic flow or the continuous flow. Good. So when you give the drug continuously, it's going to inhibit the hypothalamic pituitary gonadal axis. We are going to speak about this twice. One in endocrinology, which is later, like a second time. And the third time, it's going to be in reproductive. Pulsatile GnRH can lead to puberty and fertility. Okay, so let's speak about MSH, melanin stimulating hormone. It leads to melanogenesis by the melanocyte. Okay, so can lead to hyperpigmentation, especially in Cushing disease. What is the problem in Cushing disease? The disease, it's not the syndrome. In case of Cushing syndrome, the increase is in the cortisol. But in Cushing disease, the problem, okay, let me ask you this. In disease, is the problem in the brain or in the periphery? In disease, brain. Syndrome, in syndrome, it's going to be peripheral. For example, it could be the adrenal, but it should not be always actually. It could be also a lung tumor. So MSH causes hyperpigmentation in the Cushing disease, as MSH, ACTH, and opioid all have the same precursor, the preopiomelanocortin. Oxytocin can lead to uterine contraction during labor. So we can use it to induce the labor. It's also responsible for the milk letdown, reflux in response to suckling. So let me tell you actually a little bit about this. About the oxytocin, does it have any other function except the milk letdown and the labor? The answer, it actually does. It has something related to the bounding. I mean, I know this topic is a little bit not USMLE type of thing, but it's important. When the lady have a baby, what is the first thing we do after we get it out of her? We got the baby, we need to clean him up a little bit, and then we put him on the mother. Yes, skin to skin contact. Why do we do that? They say, well, so the mother is going to start giving milk. Yeah, so oxytocin help with that, and also it's important for bounding. I mean, it's like a chicken, for example. How the chicken knows his mommy? Because it was the first person that she was attached to after birth. Okay, so it's kind of the same story. Well, why I'm telling you about this? It's important because this explains why men tend to cheat much more than women. Why is that? Well, in ladies, they tend to have more oxytocin, so they are much more loyal than men, while men have less oxytocin. When we say somebody is in love, which hormones control love? Tell me, guys, which hormones control love? Oxytocin, that's one. What else? Hormone of happiness. What is that? Endorphin. Not really. Dopamine and serotonin. Yeah? And norepinephrine and epinephrine. You know, when you meet somebody that you really love, you did not meet him for a long time, you start having this butterfly in your abdomen. Yes? What is that? Well, this is basically the noradrenaline kicking in. Yeah? So basically love is just like all of these hormones together. In men, there is less oxytocin. So the hormone that is responsible for bonding is less. So they have less social bonding, men. Ladies have much better social bonding. But the men have much more serotonin and dopamine, which make them feel the best about love, especially in the beginning. So they lose that phase quite quick. Because they lose that phase quite quick, they want to reinitiate the phase. So what do? They cheat on their wives. Regardless of that, they do have the serotonin, dopamine, and the other ones. So they are still loyal to the family. If any of you is interested in psychiatry, this is what you are going to study in the whole psychiatry chapter. So the next thing we have here, oxytocin, So that modulate fear, anxiety, social bonding, mood, and depression. So the next one is prolactin, which decreases the GnRH. Yes, GnRH. And we mentioned this. I told you that hyperprolactinemia decreases the GnRH. And also prolactin can stimulate the lactogenesis. So some patient with a pituitary prolactinemia can have amenorrhea. Yeah? Why? Because increasing the prolactin decreases the GnRH. What happens to the FSH and LH? Quick, tell me. Low, FSH and LH is low. So estrogen, progesterone, low. So the lady gets amenorrhea, which means absence of the menstrual cycle. Estrogen is super important for bone formation, so the lady gets osteoporosis and it's absent. Hypogonadism, obviously no hormones. Galactorrhea, why? Because of the prolactin, make her like produce milk. And during breastfeeding, we have more prolactin, so we will have much less GnRH. And this is important. Why? Because when a lady comes to you after she got pregnant and had a baby, she tells you, doctor, I don't have menses. So what you should tell her? You should tell her, oh my God, let's panic. It's wrong. Something wrong with you. Or it's physiological. Don't worry about it. It's just because you are lactating. Physiological. It's all good. It's because she's lactating. She's having a lot of prolactin. Don't worry about it. They will come back in a few months. Okay. Also, if that is the case, will she get pregnant? The answer is it's difficult. Okay? Is it possible though? Yep. So don't listen at the old ladies telling you, oh, don't take a contraceptive. You will never get pregnant while lactating. Because it's true, they reduce the chance of lactating, but it's not impossible. It's still possible. Because it's still possible, if the lady comes to you and asks you for a contraceptive after giving a baby, you need to give her. But since she already has some type of a protection, you can use a mild contraceptive method, which for example mean progesterone only pills. Okay? So the next one is somatostatin, which is produced normally in which cell inside of the body, except of the brain. They are also produced in the GI, if you remember. No, not the enterocyte. Somatostatin is Dr. House. The D cells, absolutely. I cells produce CCK. D cells, which is Dr. House, produce somatostatin. What does S cells produce? S cells. S cells produce secretin, which inhibit the gastric phase and initiate the duodenal phase. Okay, so somatostatin inhibit the growth hormone, TSH as well. It's also, we call it growth hormone inhibiting hormone. And it's an analog for, we have an analog for it, which is called octreotide, and we can use it to treat acromegaly, esophageal varices, and VI bomas. Okay? So thyroxine releasing hormone or thyroid releasing hormone can increase the TSH release, but this one from the hypothalamus, this one from the pituitary, and also the prolactin. So a high level of TRH, for example, in case of hypothyroidism. So if someone has hypothyroidism because his thyroid gland was destroyed. So if his thyroid gland was destroyed, his TRH is going to be, oh my God, the thyroid level is super low. Let's try to do something about that. So he starts increasing the TRH, which can indirectly increases the prolactin secretion, leading to galactorrhea. I hope it makes sense. So let's discuss what is written down there. Let me start from the left. When you have a high amount of corticotropin releasing hormone, you are going to get a high ACTH, MSH, and also endorphin. Yes, all of this is happening in the basophilic cells of the anterior pituitary. Guys, there is the basophilic ones and the acidophilic ones. To be totally truthful with you, it was difficult for me to memorize which one is what. So in the end, I decided just to memorize the acidophilic one, and that helped me. Like, if you know this, you can know the other ones. So the acidophilic or eosinophilic cells produce prolactin and growth hormone. So the prolactin can lead to inhibition of the GnRH. So in case of hyperprolactinemia, you can get amenorrhea because low FSH and low LH. Also, prolactin can be stimulated by thyroid releasing hormone, which can be increased in cases of hypothyroidism. The normal function of the thyroid releasing hormone is to lead to more TSH secretion. Also, somatostatin, remember, since GI, we spoke about it, he liked to inhibit everybody else. So it also can inhibit the growth hormone and the TSH. Dopamine can inhibit the prolactin and also can inhibit the TSH. So when you use a drug like an antidopaminergic, antipsychotic drug, you can get hyperprolactinemia, and sometimes also you can get hyperthyroidism. Hope it makes sense. So the next thing is about the growth hormone, and after that we take a break. Let me just check the charge. Okay, that will help us until the break. So in case of the growth hormone here we go. So how I'm going to explain hormones. We study the graph, then we speak about what is written. So they say here, growth hormone releasing hormone. What stimulates it? Sleep. At what time, how many hours should a teenager sleep per day? Teenager between 12 until 18. A teenager should sleep between 8 to 10 hours. What about us adult over 25 years old? 7 hours are enough. 7 hours are enough. So if you sleep more than that, you are lazy. That's not normal. So what about something else that can stimulate it? Hypoglycemia and stress, all of these stimulate the growth hormone releasing hormone. So what is a stressful situation in medicine? I like when everybody answers at exam. Well, that's in real life, but I mean, yeah, surgery, absolutely, surgery. Good. So stimulation of the growth hormone releasing hormone, which is from the pituitary, can lead to the anterior pituitary to be stimulated, which is going to produce a growth hormone. The growth hormone is going to the liver because I told you, mostly the growth hormone does not function directly. It can, but mostly indirectly. So the growth hormone goes and it's lead to increase in the IGF-1, and that IGF-1 is going to work on the muscle and the bone to lead to growth. Growth hormone also can work directly on the fatty tissue, which increases lipolysis and decrease glucose uptake. Why it would do that? Well, by doing that, you will get more sugar going into your muscle and bone, which will make them stronger. So look what they write. The IGF, which is the functional form of a growth hormone released from the liver, which stands for insulin growth factor, insulin-like growth factor number 1. It can work on the bone, leading to more amino acid uptake, more protein synthesis, and more DNA and RNA synthesis to make more cells. And something called chondroitin sulfate, that's something we'll speak about later. It's in the structure of the bone, basically. And collagen and increased cell size and number. Basically makes your bone stronger. What about your muscles? Get more amino acid in them. We need amino acid to make more proteins, which is the process of translation, making us more stronger muscles. Excellent. So when you have too much growth hormone, that is going to inhibit the anterior pituitary and the growth hormone releasing hormone. Okay, so IGF-1 can inhibit also both the anterior pituitary from producing growth hormone or the hypothalamus from producing a growth hormone related releasing hormone. So I'm going to ask you a question. Growth hormone releasing hormone makes growth hormone makes IGF. If they give you a patient and they tell you, oh, patient X, growth hormone release, oh, first of all, he's short, person X is short in stature, he's really small, and obviously he has a growth hormone problem. So growth hormone releasing hormone is, in this patient, is really, really high. And his growth hormone is really, really high. And his IGF is really, really high. And they ask you why this patient have this problem, why he's short. Well, the answer that this patient receptor for the IGF is defected, okay? So it's like diabetes mellitus type 2. Everything exists, you have the insulin, but the receptor is not working. So, and does this syndrome have a name? Yes, it's called Laron syndrome, okay? They tend to ask it in the USMLE, so yeah, keep it in mind. Laron syndrome. Okay, so growth hormone, also known as somatotropin, secreted by the anterior pituitary, stimulate linear growth. I am 6 foot tall. I am 7 foot tall. You have more linear growth than me. And also the muscle mass through the IGF-1. IGF-1, also known as somatomedin C, which mediates the function of the somatotropin. That's why we call it somatomedin. Secretion by the liver. So also they can lead to increased insulin resistance, which makes it, this hormone, the growth hormone, diabetogenic. And it's released in pulses in response to growth hormone releasing hormone. So it's released in pulses, something like this, pulsatile fashion, okay? So secretion increases during exercise, deep sleep, puberty, and hypoglycemia, stressful situation as well. And it can decrease, secretion decrease by glucose. And they like to ask a question about this actually. I don't know why they like it, but they do. Glucose decrease the growth hormone releasing hormone. And somatostatin, well, it's a statin, which means like it's static function. It inhibits. Somatomedin, which is this guy, it can inhibit it. Okay. Regulatory molecules secreted by the liver in response to growth hormone acting on a target tissue. And excess secretion of the growth hormone from in cases of pituitary adenoma can lead to acromegaly in adult, which is a disease we are going to speak about later. They will have a really wide jaw, a big head, and it occurs in adult. I mean, it can occur in me. I'm now healthy, but in the future, I might get this pituitary adenoma and get it in an older age. The most complaint on the USMLE is the patient hat size increased. I know it's weird. It sounds like from the early 19th century. Nobody wears a hat now like they used to. But yeah, so the patient will be complaining of increased hat size or gigantism in case of children. So the treatment is with using somatostatin like octreotide and surgery. Okay guys, so let's take a little break. After the break, we'll come back. We'll speak about antidiuretic hormone, prolactin, and thyroid hormones. So see you guys in 10 minutes. Welcome back everyone. So let's keep going with this endocrinology chapter. As you can see, it's not that difficult. There is so many connections. But it's not difficult. Antidiuretic hormone, also known as vasopressin. Well, logically, will it vasoconstrict or vasodilate? What do you think? Well, if I'm going to call it vasopressin, it must vasoconstrict. The next thing we are going to speak about is where it comes from. So it comes from the hypothalamus. The same idea as oxytocin. So it comes from the hypothalamus, from the supraoptic and the paraventricular nuclei. But it's going to be stored and secreted from the posterior pituitary. How does it make it from the hypothalamus to the posterior pituitary? Using something called neurophysin. Neurophysin. Okay, so the function, it regulates blood pressure using the V1 receptor, which lead to vasoconstriction. Also, it can lead to control of the serum osmolality using the V2 receptor, which is located in the collecting tubule, and help to reabsorb the water utilizing something called aquaporin. So its a primary function is serum osmolality regulation, okay? So for example, when there is a lot of ADH, you are going to get a decrease in the serum osmolality and more urine osmolality. Why? Because you are sucking all of the water from the urine. When you suck the water from the urine becomes much more osmolar. Okay. The regulation happens via aquaporin channel insertion into the principal cells, which are located in the collecting tubule and the distal portion of the distal tubule. Antidiuretic hormone level is decreased in cases of central DI. So what is DI? Diabetes insipidus. Why it's called like that? Let's think about it. In cases of diabetes mellitus, what is the most initial sign of the patient? Yes, they have polydipsia and polyuria. Diabetes insipidus. What does the word insipidus mean? Yep. So in case of diabetes insipidus, it's not a real diabetes, okay? And thus, the patient is going to basically not have sugar in his urine. Instead, he's going to have salts. So let's try to understand what happens in this case. This patient is going to have no ADH. And when he has no ADH, can he reabsorb the water back to his body? If he has no ADH, the answer is no. So he is not able to reabsorb water, which means a lot of water are going into the urine. So he's going to have a polyuria. That's the central cause. What about the nephrogenic cause? The nephrogenic cause happens because ADH does exist. It's normal or even increased, but it's unable to attach to its receptor. So the ADH is unable to attach to the receptor, which is located where? The receptor is located in the collecting duct of the kidney. Okay? So, nephrogenic DI can be caused in a mutation of the V2 receptor, which is located in the collecting duct of the kidney and the distal portion of the distal convoluted tubule. Desmopressin, it's an analog for ADH, and it can be used to treat central, not a peripheral, central DI. For a peripheral DI, we can use thiazide and miloride, which I will explain how it works a little bit later. And also, ADH can be used for treatment of nectorial anuresis, which is basically that boy who keeps coming to you with his mother because of urinary incontinence during the night. He keeps being himself in the bedwetting. So the regulation. How do we regulate antidiuretic hormone? Plasma osmolality is the main regulator, and hypovolemia. If the patient has hypovolemia, what is going to happen to the antidiuretic hormone? Up. Okay, if your plasma osmolality is down, what happens to your antidiuretic hormone? I just tricked you. It's low. Well, if you have a low osmolality of the plasma, that means you have a plenty of water in the plasma. So you need less water. You need less ADH. Okay, the next topic is about the prolactin, mainly produced by the anterior pituitary. They are writing that it's structurally homolog to the growth hormone. We'll see the relationship with that in a bit. But for now, the function. The main function of the prolactin is to increase the production of milk in the breast, and it also can lead to inhibition of the ovulation in the ladies and the spermatogenesis. How it does that? Well, I told you that the prolactin can reduce the GnRH. So high prolactin decreases GnRH, which reduces FSH and LH, which lead to estrogen, testosterone, and the progesterone all to be low. Okay? So they write here, in males, the patient are going to have less spermatogenesis by inhibiting the GnRH synthesis and release. Excessive amount of prolactin is associated with decreased libido. What is libido? Does anybody know what is libido? Absolutely, the sexual desire. Libido basically means the sexual desire. Libido exists in both men and women. And some condition can lead to decreased sexual desire. This is abnormal. All men and women must have sexual desire. Some have it more than others, but overall we should all have it. If it does not exist, that's pathological. So for example, if we are speaking about which medication can lead to decreased libido, an idea? Except the prolactin, of course. Well, the answer is SSRIs, okay? Selective serotonin reuptake inhibitor, which are antidepressant. Okay, so let's speak. Oh, nice. Okay, somebody wrote antipsychotic. That's also correct. He said antipsychotic because they inhibit the dopamine. When you inhibit the dopamine, what is going to happen to the prolactin? Up. So the prolactin will be up. What is going to happen to the GnRH? Low. So what is going to happen to the FSH and the LH? Low. So what is going to happen to the estrogen, testosterone, and all of this stuff? Low. Guys, I have a question. In women, and be careful about this question. In women, what controls the libido, which is the sexual desire? Is it testosterone or estrogen? Testosterone. Yep. In men and women, the thing that controls the libido is testosterone. So, regulation. Prolactin secretion from the anterior pituitary is tonically inhibited by dopamine from the tubuloinfundibular pathway of the hypothalamus. So this tubuloinfundibular pathway is a pathway that I'm going to explain for you more in neurology, but just for the sake of like just having an idea what I'm speaking about, I'm just going to show you it once, but it's not our topic for now. So take a look here. You can see the tubuloinfundibular pathway, the red one. Yep, that guy. So basically, as you can see here, it has a function connecting the basically the hypothalamus into the anterior pituitary. Okay, so prolactin in turn inhibit its own secretion by increased dopamine synthesis and secreting from hypothalamus. Let me reread that because I feel I did not understand what I just read. So prolactin secretion from the anterior pituitary is tonically inhibited by dopamine. Yes, dopamine does inhibit prolactin. That's why antipsychotic increase prolactin. So yeah, because we will have stimulation of the tubuloinfundibular pathway by the dopamine. Prolactin in turn inhibits its own secretion by increasing dopamine synthesis and secretion from the hypothalamus. Yes, that's correct. So when you have increase in the prolactin, how does your body know that it's enough? I should stop secreting prolactin. Well, prolactin increases the secretion of dopamine. And when the dopamine is high, that is going to go and inhibit the anterior pituitary from producing more prolactin. So that's what they say. Prolactin in turn inhibits its own secretion by increasing the dopamine secretion and synthesis from the hypothalamus. Okay, so TRH, which is thyroxine releasing hormone, increases the prolactin secretion. For example, in cases of a primary and secondary hypothyroidism, we have an increase in the TRH, and that can lead to basically hyperprolactinemia symptoms. Okay, so let's speak a little bit about the graph, then we will speak about the drugs. So they mention the sight of the baby or the cry of the baby is going to activate higher cortical center, which is basically our human brain, our higher cortices. And that's what makes us a human, basically. It's the cortex. A lot of people ask, oh, does insects have feeling? Actually, this is interesting topic. That would be beneficial for us in neurology, so let me take 2 minutes to explain this topic. First of all, we have 3 types of a brain. Brain number 1. Brain number 1 is known as the rabtile brain, which means I want to eat, I want to sleep, I want to drink, I want to have sex. So this is we call the rabtile brain. Do human beings have rabtile brain? Yes, we do. Do cats and dogs have this brain? Yes. Do insects have rabtile brain as well? Yes, absolutely. Wanna eat, wanna drink, wanna have sex. Okay, so let's try to make it more difficult. Emotions. Well, do insects have emotions? Which is basically limbic system. Limbic system does not exist in insects. That's correct. So no emotions. What about cats and dogs? Do they have limbic system? Yes, they do. You know, your kitty comes to you like meow, meow, meow. Yes, it has emotions. What about humans? Do they have emotion? Not all of them. Okay, good one. Yeah, so they do also have emotions. Okay, so the last one. Neocortex. I'm not saying cortex, I'm saying a new cortex. A new cortex is the most developed portion of our cortex, which I will be explaining more in neurology. It's responsible for cognition. I mean, the ability to know that, oh my God, I'm here, I can have control over other stuff. So, do insects have insects? Do they have consciousness? Insects. No, they don't. Do cats and dogs have consciousness? They don't. Do humans have consciousness? Yes. And it's because of the neocortex. It's not because of the rabtile brain, which is made out basically of the brainstem. It's not because of the limbic system. It's made out of the neocortex. Okay? This topic will be more for neurology, so just give it some time. Okay, anyway, higher cortical activity lead to working in the hypothalamus. For example, in this case, they lead to inhibition of the hypothalamus, so you will have less dopamine, so you will have less inhibition of the anterior pituitary. Less inhibition means more prolactin. More prolactin means more milk production. Okay, they mentioned that renal failure can lead to more prolactin. Yes, because prolactin is eliminated by the kidney, and if the kidney is not working, you will have more prolactin. Prolactin can lead to reduction of the GnRH, which can lead to less spermatogenesis, less libido, less ovulation, and amenorrhea. In cases of a pregnancy, you will have more estrogen and more why women? That's why postpartum depression. You are saying that why ladies have postpartum depression? Well, yeah, this hormonal mechanism, it's one of the causes, but it's not the main cause. Other causes will be, I'm going to explain some of them in the future. Some of them are related that, oh, their oxytocin did not kick in, okay? Or they started to have a huge reduction of the dopamine, okay? So that's also, it's quite serious, and serotonin. So we have something called postpartum blue, postpartum depression, and postpartum psychosis. These 3 diseases we'll speak about in psychiatry. just for the sake of, if you see a case until we do psychiatry, if you see a lady with postpartum psychosis, the symptoms is, doctor, I'm too tired. I don't want to live with that. I have a loaded gun in my house and I don't want the child anymore. What should you do in that case? Hospitalize her immediately, remove the child from him because they tend to kill the child, okay? And then kill themselves. This is postpartum psychosis. If you notice it, act on it. They are not having normal brain. They are hallucinating. Okay? So, until we reach that topic, just I'm telling you about the emergency thing to do. If you get a case of postpartum psychosis, she's telling you, and she will tell you that she is feeling empty from the inside and that she feels like no emotion for this baby. And if you ask her if she has any thoughts of suicide, she will be like, yeah, well, I was thinking about it. And the next question always, if someone tell you he want to kill himself, what is the next question? If one of your friend comes to you, tell you, I'm too tired from medical school, I want to kill myself, what should you ask him? Do you have a plan? If he says yes, tell him, well, what is it? If he tells you the plan, this person is serious about it and he really seeking your help not to do it. It's serious. But if you tell him, do you have a plan? And he tells you, well, not really. I was just like tired yesterday because we had an exam and yeah, I thought about killing myself. That's okay. But if he has a plan, that means that he's thought about it and he really want to do it. That's when your job comes to act. Okay. So the hypothalamus will work on the, when we have more prolactin as well, we said we will have less ovulation, less spermatogenesis. Good. So sometimes as well, we can have a stimulation of the prolactin, again, by inhibiting the inhibitor, which is dopamine, with some medication like the antipsychotics. Also, chest wall injury via activation of the autonomic nervous system. And lastly, and most importantly, nipple stimulation. When the baby starts suckling on the breast, the baby starts coming. Guys, do you know other way? They spoke about oxytocin up there, but they did not speak much. I told you that it can lead to induction of the labor. Can you tell me a way that we can increase the oxytocin release? A medical maneuver? Yes, yep, it's sex. Well, let me tell you why we use it. Actually, not us. We use it in an indirect way. Okay, let's say that the lady, she needs to deliver, you know, like she's having this protracted labor. It's taking a lot of time for her to deliver. And you tell her, okay, would you like me to inject you with oxytocin? And she'll be like, no, I don't like to get any medication inside of my body. Well, you tell her, would you like to have your husband inside of your body? If she says yes, you can make her have sex with her husband and that induces the labor. I know, amazing. Because that increases the oxytocin, which stimulates the contraction of the uterus, which allow her to get a baby much more quicker. Okay, thyroid hormones. Thyroid produces the T3 and the T4 known as the triiodothyronine and, oh, wait a second, I missed something. Sorry. Dopamine agonist like a bromocriptine can lead to inhibition of the prolactin secretion. It can be used to treat prolactinemia. Note, a bromocriptine is a dopamine agonist. Dopamine is the hormone of happiness. If you have so much of it, what will happen to you? You will start doing some really serious, stupid stuff. Psychopaths have a lot of dopamine. But if you give this medication, the symptoms, manic people have a lot of dopamine. If you give this medication, the most common symptom is gambling, okay? Gambling. They will be like, oh, well, doctor, yeah, I just like took a loan for $100,000 and I went to the casino and played with $100,000 and lost all of them. after you prescribe me this amazing medication? Yeah, that's on you. Why? Because when you prescribe your patient this medication, you should tell him, listen, man, this thing is going to make you more hyper. So do not do any major purchases during this period, okay? Because he will feel more into it. Okay. So dopamine antagonist, most antipsychotic, and also anti-vomiting drug like metoclopramide, and estrogen like oral contraceptive pills can lead to stimulation of the prolactin secretion because dopamine normally inhibit the prolactin. Now the thyroid hormones. We have T3 and T4, triiodothyronine and thyroxine. Iodine containing hormones that control the body metabolic rate. So when we speak about thyroid hormones, they have a lot of iodine. Where do we get iodine from? Any idea? Yeah, well, normally it exists in some food, fish, stuff like that, but most of industrial cities don't have it. So what government started to do is to put like iodine inside of the salt, okay? So they started to put iodine inside of the salt, which is actually a good thing. So they say the source is from the follicle of the thyroid. Let me just check. Okay, this is good. So quick histology of the thyroid, so I can start speaking about it. Not history. Histo. Seriously? Okay, good. So you can notice here that we have a colloid in the middle, and then we have these follicular cells around it. Yeah? So they write here, this is just the follicular cell, this is the colloid in the inside area, and this is the blood vessel. So the hormone is produced by the follicle. It's a 5' deiodinase, converts the T4 to the T3 in the peripheral tissue. Let's take a look. So after you produce the T4, they are starting from the ending. Okay, anyway. So when you have T4, it can be converted to T3 using 5' deiodinase, okay? Which is an enzyme. They write, the peripheral conversion is inhibited by steroid, beta blocker, and propylthiouracil. So there is here T4 and T3. Which one of these two is more active? Is it T3 or T4? Yes, it's T3, absolutely. So T3 is much more active, and thus, if someone is complaining of hyperthyroidism, you would like to inhibit this, yeah? With propylthiouracil, also, you can use other drug like beta blocker or steroids. Which type of beta blocker are you going to use? Is it selective or non-selective? Non-selective. Selective will only work on the heart, so you must use non-selective beta blocker like propranolol. So reverse T3, or also written as an RT3, is a metabolically inactive byproduct of a peripheral conversion of the T4, and its production is increased by growth hormone and steroid. So let's take a look at that. So as you can see here, we have like, if you use a steroid, beta blocker, something like that, you will have accumulation of the T4 and less T3. To be fair with you, you will also have more reverse T3, which is an inactive form of the thyroid hormones. Function of thyroid peroxidase include oxidation, organification of the iodine, and coupling of the MIT and DIT. So you're like, wait a second, what is that even? Well, let's take a look at them one by one. So the first function of the thyroid peroxidase was oxidation. What is that? Well, if you come here, take a look here. You intook the iodine from the periphery because you ate that iodinized salt, for example. So the iodine will make it into your thyroid, but it has this negative charge. You need to make it more positive. For that, you do the process of oxidation. Okay, so you have iodine. Excellent. What is this? TG. This is known as thyroglobulin. Thyroglobulin. This thyroglobulin with the iodine is going to undergo the process of organification, which is basically connecting one iodine or two iodines. Mono means one, di means two. So what does the T stands for here, guys? An idea? Well, does anybody know? Mono, iodine, and this? Tyrosine. Tyrosine. What is tyrosine? Tyrosine is an amino acid, basically. And this is a common question. They ask you, oh, thyroid hormones are made from which of the following precursor? The answer is tyrosine. The organification is coupling the is putting the MITs and the DIT in the thyroglobulin, while the coupling reaction is the creation of the T3 and T4. How to create T3 and T4? MIT has how many iodine? Tell me, please. How many iodine in T3 in MIT? 1. Yes. So if I want to make a T3 out of it, how can I make it? I need to combine MIT with DIT. Yes. So in total, I'm going to have a 3. Yes. Iodine. So that's T3. Okay, how I'm going to make T4? Any idea? DIT with DIT. You can get T4. Good. We created T3 and T4. Let's get it back into the follicular cells. Of course, all of this process happens inside of the colloid, yeah? Which is this big area. Okay. So we endocytose it. Thyroglobulin now is binding to MIT, DIT, T3, and T4. So the MIT and the DIT will be released back to reusage inside of the body, while the T3 and the T4 will be cut like this using a proteases, and they will be released into the circulation, and they can lead to inner function of the peripheral cells, which is something we are going to discuss now. Okay. So what they do exactly? They write, thyroid peroxidase function include oxidification, organification of iodine, and coupling of MITs and DITs. It can be inhibited by propylthiouracil or methimazole. These two drugs are considered as an anti-thyroid agent, which are utilized in cases of hyperthyroidism. DIT with DIT, you get T4. DIT with MIT, you get a T3. So there is something called the Wolff-Chakoff effect. What does that mean? Well, it's type of a protective function. If you bring somebody and he's hungry, you buy for him, I don't know, sushi. You feed him sushi, he's happy. Feed him more sushi, he's happy. If you keep giving him sushi, will he like sushi anymore? No. He will like, stop it. Yes? So he will stop consuming the sushi regardless of the fact how much you give him. Okay? It doesn't matter how much you give him sushi. He will be like, no, thank you, I don't want that anymore. So that's what is Wolff-Chakoff effect is. It's a protective autoregulation, which means when you give a sudden exposure to an excess amount of iodine, that will temporarily turn off the thyroid peroxidase, which means you will have less T3 and T4 production. So when you hit the follicular cells of the thyroid with a lot of iodine, they will stop to function. Well, do we use that in medicine? The answer is absolutely yes. Let's imagine that a tragedy just happened near you, a nuclear reactor just got exploded. Okay, a nuclear reactor just got exploded. What can you prescribe for your patient? The answer is iodine. But not topically, of course, they need to swallow it. Why? Because the iodine will go in a massive amount and it will get into the thyroid. If you give the patient excess iodine, will this pump intake the radioactive iodine. No way. So when you, the doctor, give the iodine, the radioactive iodine, which is in the air, will not be intaken by the cell. That means you will be protected from the papillary thyroid cancer caused by radiation. Okay, do we have a real story that we had an actual nuclear disaster that led to so many cases of papillary thyroid cancer? Yes, correct. So two of them, two main ones. The first one is the Chernobyl disaster, which happened in Ukraine back in the Soviet Union. And the second one was where? Fukushima, which happened in Japan. Nice. Also in Hiroshima and Nagasaki as well. But regardless of the radiation effect in Hiroshima and Nagasaki, they were not as much as in Fukushima and in Chernobyl, because during the nuclear explosion in Hiroshima and Nagasaki, they used, I think, 46 kilograms of uranium, enriched uranium, but the thing that got exploded is 2.6 grams. That's it. And that killed 100,000 people. Yep. So, okay, let's speak about the function of the thyroid hormone. Only free hormone is active. When it's bound to something, it's not active. So T3 binds, oh, this is important. When we speak about hormone, guys, I want you to know that most hormones act on a receptor, except steroid hormones and also vitamin D, okay, and also thyroid hormone. These guys go directly inside of the cells and they bind to an intracellular receptor. So most hormones bind to a receptor outside of the cell, except vitamin D, steroid hormones, and T3 and T4. So the T3 binds to a nuclear receptor, so they penetrate the cells and bind to the inside of the cell with a greater affinity than the T4. So the T3 is more functional than the T4. The T3 can lead to brain maturation. So why this is important? Because if you have a baby with low amount of thyroid hormone, he can get mental retardation. I have a question. Is it reversible? Somebody wrote it, treatable mental retardation. The answer is then is yes. But if it's going to last more than 1 year of age, it becomes irreversible. So you need to detect it early. That's why in the US we check every single baby for T3, T4, and TSH the moment he was born. Guys, if they tell you which of the following is the best test to do for the thyroid, is it T3, T4, or TSH? TSH is the correct answer. T3 and T4 might be normal sometimes because they are controlled. Are they free or not? If you have so much protein in your body, they will be low. If you have too low protein in your body, they will be high because you're only checking the free one. But the TSH is fixed. So the TSH is the much more specific and sensitive indicator. The T3 also can lead to bone growth, and it's synergistic with the growth hormone, which means like when both of them work together, they get more function than one working alone. They also can lead to beta-adrenergic effect by increasing the amount of beta-1 receptor in the heart, which increases the cardiac output, more heart rate, and more stroke volume and contractility. Beta blocker alleviate the adrenergic symptoms in cases of thyrotoxicosis. That's why we prescribe it. In addition, beta blocker can inhibit the 5-deiodinase, which decreases the more active T3 than T4. Okay. They're right. Basal metabolic rate will be also increased. How come? Well, the basal metabolic rate increases via an increase of the sodium-potassium ATPase, which is going to lead to more O2 consumption. Also, the respiratory rate is going to go up and the body temperature is also going to be up. So with such symptoms, the patient is going to get everything elevated up. More energy consumption he's going to get. The blood sugar is going to have, the patient is going to have more glucogenolysis and the gluconeogenesis, okay? So that means the gluconeogenesis is the making of sugar out of a non-sugar particles, and the glucogenolysis is making of sugar like glucose out of glycogen, more complicated sugar. Breakdown of lipids, which lead to lipolysis, and stimulate surfactant secretion in the babies. That's why it's actually people who are born with kernicterism, which is a decreased amount of thyroid hormone during like the moment they were born. They might have neonatal respiratory distress syndrome. Okay, that's one risk factor. Okay, so let's speak about the regulation. First of all, we speak about this, then we speak about this. So the hypothalamus produces the thyroid releasing hormone, and then we will have something called the TSH produced from the anterior pituitary, and after that the TSH is going to work on this guy, thyroid follicular epithelial cells, and that is going to lead to more T3, T4. T3 is more functional, and they work in the effector organ. So when you have T3, T4, these can inhibit the pituitary and the hypothalamus, both of them. Somatostatin, dopamine, and steroids can inhibit the anterior pituitary from producing these substances, which are going to decrease the amount of hyperthyroidism in the body. So the regulation, more TRH, more TSH release, working on the follicular cells, and that can lead to the increased amount of the T3, T4. Thyroid stimulating immunoglobulin may be positive follicular cells in Graves' disease. Let me explain this point, actually. This is important. In Graves' disease, we have an IgG antibody, and write a note about that. They are IgG, but they are stimulatory. They work at the TSH receptor located at the follicular cells, which lead to more reuptake of the iodine and more making of the T3, T4. That's why patients with Graves' disease have hyperthyroidism, because they are going to have antibodies, stimulatory antibodies, which increase the function of TSH on the cell. The patient is going to have negative feedback primarily by free T3 and T4. Okay? So when you have a lot of T3, T4, they can go to the anterior pituitary, make it less sensitive to the TRH, which eventually is going to decrease the amount of TSH. And when they work on the hypothalamus, they will decrease the synthesis of TRH, less TSH, less T3 and T4. The last thing I'm going to explain before the break is going to be the thyroxine binding globulin, which is the thing that moves the T3 and the T4 around inside of the blood. So we have a protein called thyroxine binding globulin, which exists in the blood and helps move the thyroxine, T3 and T4 inside of the blood. But keep in mind, when these hormones are bound, they are inactive. They're only active when they are inbound. So think about it. If you are going to have more of this protein, what is going to happen to the T3 and T4 if you have more of it? I mean the free ones. If you have, yes, absolutely. If you have more protein, less free T3 and T4. Okay. That means you will get symptoms of hypo or hyperthyroidism. Excellent. Hypothyroidism. Nice. So here they say the thyroxine binding globulin increases in a pregnancy by the effect of estrogen or OCBs. Yes, so estrogen increases the TBG. That means you will have higher total T3 and T4. But what will happen to the free T3, T4? The free T3, T4 is going to be low. which lead to symptoms of hypothyroidism. Is it reversible? Yes, 100%. Okay? Okay, the next one. The TPG can be decreased after steroid use or nephrotic syndrome, because nephrotic syndrome, basically we are kicking proteins out. So tell me please, what is going to happen in case of nephrotic syndrome to the free T3 and T4? High. So the patient can have symptoms of hypo or hyperthyroidism? Hyperthyroidism. Done. Okay, good. So let me just take a quick look. We finished 1, 2, 3, 4 pages. Let's take 10 minutes break, come back, finish 2 more pages, and we will call it off. See you guys in 10 minutes. Okay, everyone, welcome back. So the next topic is going to be about the parathyroid hormone. First of all, we need to know what is parathyroid gland and how many parathyroid glands do we have. Any idea, guys? How many parathyroid glands do you have? No, we actually have only 4 parathyroid glands. So the parathyroid gland you have 4 of them, and they are located posteriorly behind the thyroid gland. So this is an anterior view, and this is a back view of the thyroid gland. 1, 2, 3, 4. Why their number even matters? Because there is one surgery for some condition in which we remove 3.5 glands and we keep a health one. Okay? So that will be important in the future. Okay, so let's take a look. Okay, recording. So the source, it comes from the chief cells of the parathyroid gland. So the main function, I like always to tell myself, okay, there is a bone and there is the blood. The function of the parathyroid gland is the process of resorption. It's not reabsorption, it's resorption. Resorption means to break down. Reabsorption means to suck back in. So the parathyroid hormone lead to resorption of the bone, which lead to the calcium to get released into the blood. So more free calcium in the blood, that's the primary function. More calcium and phosphate absorption from the GI, and more calcium and phosphorus release from the bone, which we call bone resorption. Keep in mind one thing here. Parathyroid hormone reabsorbs calcium from the DCT, but it trashes the phosphorus from the BCT. So yes, from the GI it reabsorbs both, but from the kidney it reabsorbs only the calcium, but it trashes the phosphorus. Okay, good. That's why which disease that lead to dysfunction of the BCT lead to hyperphosphatemia due to failure of trashing the phosphorus? It's Fanconi syndrome, absolutely. Also, the BTH parathyroid hormone can lead to increased amount of 125 hydroxyvitamin D, because basically it leads to stimulation of, so they say more production of this guy by activating the 1-alpha hydroxylase located at the BCT. Good. So they write, BTH increases serum calcium, decreases serum phosphorus, and increases urine phosphorus by trashing it from the BCT. Also increase the urine cyclic A and B. Good. So they write, there is something called the rank L and the rank. This is a concept we speak about again in MSK. Now I will try just to give you an overview about this thing. And basically, first of all, we have 2 cells. One is called osteoblast and one is called osteoclast. Both of them work on the bone. If we say this is a bone, if we speak about osteoblast, that build up the bone. Osteoclast, that destroys the bone. Okay? So on the osteoclastic cells, on them, there is something called rank. And the osteoblastic cells have something called rank L. Okay? So there is rank L, which is basically a ligand, okay? And there is rank. So to activate an osteoclast, you need an active osteoblast. I mean, if you want to destroy the bone, you need the cell who normally produce the bone to bind its rank L to the rank to stimulate the osteoclastic cells to lead to destruction of the bone. Let's see what they write. Parathyroid hormone increases the rank L. When they increase the rank L, they write receptor activator of NF-kappa B ligand secreted by osteoblast and osteocyte. As you can see here, it's on the osteoblast. Okay, so they can bind to the rank receptor, which is located at the osteoclast, and their precursor. As you can see, it's binding to the osteoclast, which stimulate the osteoclast and thus increase the calcium level by bone resorption. Yep, it leads to working on the bone. It's a clast, so it leads to lysis of the bone, which is the resorption of the bone. Intermittent PTH release can also stimulate bone formation. Yes, so if you have a low amount of PTH release, that will increase the calcium inside of your circulation. I mean, from the GIT and from the kidney, which can increase the bone formation. But if you have a huge amount, like in case of hyperparathyroidism, that is going to definitely destroy your bone. Okay? BTH, phosphated trashing hormone, where does it trash it from? Is it the BCT or the DCT? The trashing of the parathyroid hormone. The BCT. What about the reabsorption of calcium? Is it the BCT or the DCT? The DCT. Good. Parathyroid hormone related peptide function is exactly like PTH, but it's not PTH. It's commonly increased in some malignancies like squamous cell carcinoma of the lung, renal, squamous cell carcinoma, and renal cell carcinoma as well. Also, it can be squamous cell carcinoma of the head and the neck. It can be squamous cell carcinoma of the cervix. It doesn't really matter. Any squamous cell carcinoma can lead to production of the parathyroid hormone related peptide. So how do we regulate the PTH? Well, if you have low calcium, PTH is produced, so you will reabsorb more. If you have high phosphorus, PTH is produced more. Why? To trash the phosphorus. But this is actually quite interesting. I have to say this one is weird. If you have low magnesium, your PTH goes up. If you have severely low magnesium, that will lead to decrease in your PTH. I will tell you something about this in a moment. So common causes of decreased magnesium include diarrhea, aminoglycoside, diuretic, and alcohol use. Anyway, the general principle to know in this case. If you have low amount of magnesium, that increases the PTH because it makes the parathyroid gland less sensitive to the calcium level. So it fakely tells it that the amount of calcium inside of the circulation is low, regardless of the fact that it is not low, which increases the parathyroid hormone release. Again, this is the parathyroid gland. If the parathyroid gland normally produces PTH, but to produce the PTH, it has a receptor on it that tells her how much calcium is there in the circulation, okay? The magnesium, when it is low, it inhibits this sensation. So the PTH goes up. But when it is severely low, it inhibits the whole gland itself, okay? So, they're right. PTH activity. It can be activated by a low amount of calcium, high phosphorus, or a low amount of 125 hydroxyvitamin D, because the PTH makes more 125 hydroxyvitamin D, by stimulating the 1-alpha hydroxylase. So you have 4 parathyroid glands located behind the thyroid gland, and they can have parathyroid hormone released into the circulation, which is going to lead to work on renal tubular cells, and that increased 125 hydroxyvitamin D synthesis and reabsorption of the calcium can occur, a trashing of the phosphorus, and that leads to the urine calcium becoming low and the phosphorus becoming high in the urine, of course. Okay, good. So in your circulation, you are going to have high calcium, low phosphorus, which is going to inhibit the parathyroid gland. And this process can be inhibited by magnesium, yes? So by low magnesium, sorry. Also, the parathyroid gland, the parathyroid hormone, can increase the 125 hydroxyvitamin D, which also can inhibit the parathyroid gland. Keep in mind that parathyroid gland can lead to activation of the 25 hydroxyvitamin D into the active form, which is the 125 hydroxyvitamin D. Previously, the 25 hydroxyvitamin D is normally stored inside of the liver, and it's the storage form of vitamin D. It's not the active form. Also, decrease in phosphorus can stimulate this process. A high amount of 125 hydroxyvitamin D can lead to increased reabsorption of the calcium and the phosphorus from both the intestine and the bone, leading to increase in both calcium and phosphorus. So let's speak a little bit about calcium homeostasis. So the calcium exists in 3 forms. There is a bound one, and a free one, and an ion one, bound to an ion. So we spoke about this concept previously. Always the active form is the bound or the inbound form. What do you think? The free one. Absolutely. The free one, unbound, is always the active one. Okay. So if the pH goes up, and to understand this concept, I'm going to draw some stuff here. So they say high pH, which means less hydrogen, means the albumin will bind more calcium, which means less ionized calcium. So let me explain what does that even mean. So normally we have this albumin molecules, okay? This is an albumin. Let me write a little A on it for you to know that it's an albumin. I hope you will be concentrated with this topic because it took me a lot of time to understand it. So albumin normally have some hydrogens on it. Let's imagine that it has 4 hydrogens. Obviously it's more, but for the sake of illustration, let's just imagine it's only 4. So it has 4 hydrogen in it. So if you have high pH, what happens to the number of hydrogen? If you have high pH, what happens to the number of hydrogen? It goes down. Okay, actually before it goes down, yes, so calcium, okay. So let's say the patient gets high pH, so the hydrogen goes down, so 1 hydrogen was lost. In that place of that 1 hydrogen, you need to put something instead of it, which is the what? The calcium. So you take the calcium and you put it here. Good? So the calcium went outside of the here and came here. So the calcium became bound. If the calcium became bound, the ionized form or the free form of calcium, is it up or down now? Down. So if it is down, the patient is going to have symptoms of hypo or hypercalcemia. Excellent, hypocalcemia. Can you tell me please what will happen to the total calcium level inside of the circulation though? The total amount of calcium. The same. No, it will be the same. Why? The total amount of calcium mean free calcium plus the calcium bound to the albumin plus the calcium bound to an ions, which is like the total, okay? So the total will be normal, but the free one will be reduced. The one bound to the albumin will be increased. Okay, so the patient with high pH is going to have less ionized calcium, leading to cramps, pain, paresthesia, and something called carbopedal spasm. Okay? So the patient is going to have, because of that, he's going to have a fake hypocalcemia leading to increased PTH amount. Okay, let's say the other story happened. If the patient have low pH, what is going to happen to the amount of hydrogen? Yes, it will go up. If it had a calcium here, it will kick it out to put more hydrogen in its place, correct? So that will lead to increased amount of free calcium. So that will give you a fake hypercalcemia. So they write decreased pH, more hydrogen, lead to albumin bind less calcium. Thus you will have more free or ionized calcium, and thus your BTH is going down. So they write, free calcium is the primary regulator of the BTH, not the one bound to the albumin, not the anion. Only the free one is the active form. So changes in the pH alter the BTH, changes in the pH can alter the BTH secretion, whereas changes in the albumin concentration will not lead to anything with the BTH because we are speaking about the free type of calcium. Okay, the next hormone is called calcitonin. Again, the painting for the bone I did for you. So this is the bone, this is the blood supply. The parathyroid hormone led to resorption of the bone. Yes? Now we have a hormone called calcitonin, which is produced by the thyroid gland itself. Keep in mind, the thyroid gland has two cells. It has the follicular cells, and it has something called the parafollicular cells, also known as C cells. So the C cells, also known as the sheath cells, produce something called calcitonin. Calcitonin takes the calcium from the periphery, put it back to the bone. That is the function of calcitonin. So it decreases the bone resorption, increase serum. So the regulation, it's when you have high calcium inside of your serum, calcitonin will be secreted. Why? So the calcium will be sucked from the blood back to the bone. Calcitonin opposes actions of PTH and not important in normal calcium homeostasis. Let's try to understand that. So PTH and calcitonin are enemy of each other, which means it's the exact opposite. But calcitonin compared to the PTH is ridiculous. He's not as strong as it. So not important in normal calcium homeostasis. Calcitonin tones down the serum calcium level and keeps it in the bone. So yeah, calcitonin keeps calcium in the bone. Glucagon, it's made by the alpha cells of the pancreas. Beta cells make insulin. And the function of a glucagon is the opposite of insulin. So it promotes glycogenolysis, which increases the glucose, which is the process of destroying glycogen into many particles of glucoses. Gluconeogenesis will be increased, which means more glucose. Lipolysis will be increasing, which eventually means more glucose. Ketogenesis will be increased. So elevated blood sugar level to maintain homeostasis when bloodstream glucose falls too low, like for example in the fasting states. Okay? The regulation, it's secreted in response of hypoglycemia. So when we get a hypoglycemia, we need a glucagon to fix that. Also, it inhibits the insulin, amylin, somatostatin, and hyperglycemia. Basically, what I want you to know that when you have insulin, when you have amylin, somatostatin, or hyperglycemia, all of these will be able to inhibit the glucagon. So if somebody has severe hyperglycemia, he does not need a glucagon because a glucagon, it increases the sugar. His sugar is already high, so you want to decrease its function. Okay? So, okay, we finished 6 pages from, let me count really quick. 1, 2, 3, 4, 5, 6. Good. So 6 pages. Tomorrow is off, but on Monday we'll finish 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. And 1, 2, 3, 4, 5, 6. And 1, 2, 3, 4, 5, 6. Yes, until Friday, we will be done with this endocrinology, and we'll be starting the new system. Let me just take a quick look at this, and I want you guys just to help me really quick and remind me. Did we speak about, I remember we spoke about this page, but I'm not sure if we spoke about the rough and the smooth endoplasmatic reticulum. Did we speak about these? Not yet. Okay, so allow me just 5 minutes. I will be speaking about this and then we can call it off. So we have something called the rough endoplasmatic reticulum and something called the smooth endoplasmatic reticulum. The rough endoplasmatic reticulum, what makes it rough is the presence of ribosomes. What is the function of ribosomes? Really quick. Come on, guys. Function of ribosomes. They make what? They make proteins through the process of translation. Okay. Well, can somebody tell me what ribosomes are made out of? I know 40S, 60S subunit, but what they are made out of? I hope you are thinking rRNA, which is normally made where? Where do we make the rRNA, which is the ribosomal RNA? It's made normally in a portion of the cell called the nucleolus. The nucleolus. The nucleolus was the most dark structure located inside of the nucleus. Okay? That has rRNA. So if they show you, and they do that, they do show you a picture of electron microscopy. And they are like, oh, this is the nucleolus, of course. This is the nucleus, and this is the nucleolus. And they are like, which process is happening here? And the answer is the production of rRNA to make ribosomes. Okay, rough endoplasmatic reticulum, it's the area where we have synthesis of the secretory proteins and the end-linked oligosaccharide addition to the lysosomes and the lysosomal and other proteins. So regarding this first portion, which is the area where we have the making of the proteins that go outside of the cell, we got that. So we make proteins, enzymes, for example, trypsin, that is going to go outside of the cell. Yes? But what about the other portion? Well, they tell you that it's here we have the process of binding the oligosaccharide, end-linked oligosaccharide into some proteins. Which protein? Lysosomal and others. But what is the idea here? So how does the lysosome know that it should break down that substance? Well, because that protein will have an N oligosaccharide connected to it, or it will have a mannose residue connected to it. Okay? So when the lysosomes see that connection, they know that this is the particle I should kill. Rough endoplasmatic reticulum exists in different cells. Well, most of the cells. But Nissl bodies are a prototypical example of them, which is existing in the neurons. They synthesize peptide neurotransmitter for secretion. So our neurotransmitter are basically what? They are proteins. And they must be made inside of the Nissl body, which is this thing. So you can see the Nissl body. Which process does it occur inside of the nucleolus, guys? Any idea? Which process inside of the nucleolus? rRNA synthesis. Okay? So, free ribosomes, unattached to any membrane, they have the site of synthesis of internal proteins. So the external proteins, all of them were made where? Inside of the rough endoplasmatic reticulum. Yes? What about the internal proteins? Well, mostly, not all of them, but mostly they are made by the free ribosomes, which are just ribosomes swimming inside of the cell. So if we say that this is the nucleus, this is the rough endoplasmatic reticulum, this is the Golgi apparatus, and you have some cells like here, some ribosomes like here. These ribosomes are responsible of making internal proteins for the inside of the cell. Rough endoplasmic reticulum is, however, responsible of sending out the proteins to the outside of the cell. So they write free ribosomes and attached to any membrane. They are the site of synthesis of cytosolic or peroxisomal or even mitochondrial proteins. So end-linked glycosylation occurs in the endoplasmic reticulum, which is a function that is important for cellular trafficking, which is something I'm going to explain next class. And mucus-secreting goblet cells of the small intestine and also an antibody-secreting plasma cells are rich with the rough endoplasmic reticulum. Really common question they ask on the USMLE. They show you this. Okay. This is a plasma cell. Here it is. Oops, sorry. This is a plasma cell. Okay. They ask you, what is this? What is this? What is this? Well, this is the nucleus, no problemo. Well, what about this? This is rough endoplasmic reticulum, guys. Can you see? It's a little bit pale. And this, well, this is just the cytoplasm. So you must know that the rough endoplasmic reticulum. Well, why it's so evident in this cell? The reason that it's really evident in this cell is because the rough endoplasmic reticulum inside of the plasma cells is abundant because they make a plenty of what? Immunoglobulins, yeah? So they need to have more of it. Proteins within organelles, like the endoplasmic reticulum, the Golgi bodies, and the lysosomes, the proteins inside of them, they can be made also in the rough endoplasmic reticulum, okay? But if it was unattached, the free ribosomes, however, can make you the peroxisomal and the mitochondrial proteins. Okay, the last thing, the smooth endoplasmic reticulum. What makes it smooth? Absence of what? Absence of what makes it smooth? The ribosomes. So it's the site of the steroid synthesis. And also the process of detoxification of drugs and poisons. Write a note. The detoxification of ethanol happens here. So right, the detoxification of ethanol happens at the smooth endoplasmic reticulum. They do not have ribosomes. Also, it contains something called the glucose 6-phosphatase, which you are going to learn in the metabolism chapter. And it's the last step of glucogenolysis and the gluconeogenesis, which are two processes that makes us sugar. So liver hepatocyte and the steroid hormone have a plenty of it. So they write producing liver hepatocyte and steroid hormone producing cells of the adrenal cortex and the gonads have a lot of smooth endoplasmic reticulum. Now the question is why? Because the liver hepatocyte do the process of gluconeogenesis and glucogenolysis. What about the adrenal cortex? Well, it has a steroid hormone, and I told you that the steroid hormone are only made by the smooth endoplasmic reticulum, which is also true about the gonads, which make testosterone, yeah? Or sex hormones, basically, which are also steroid type of hormones. Okay, guys, so that's it for today. On Monday, we'll meet at our normal time, hopefully, do 6 pages from endocrinology, finish up cellular trafficking, speak about peroxisome and proteasome. So see you guys on Monday.